Today, we're going to talk about the effects of HIV and antiretroviral therapy on bone. I'm going to talk about the improvements that we've seen with the introduction of integrase inhibitors and tenofovir alafenamide fumarate on bone health. And then we'll talk about remaining management issues as well as research areas. Osteoporosis is a systemic skeletal disease of aging. It's characterized by low bone density, microarchitectural deterioration, and reduced bone strength. Its clinical manifestation of osteoporosis is a fragility fracture. Fragility fractures are fractures that happen without trauma. They usually happen at the vertebrae, the hip, or the wrist. The way that we make the diagnosis of osteoporosis is by DEXA. And there, you usually look at the T-scores. If your T-score is greater than 2.5 standard deviations below that of a person of the same sex and race as you at a young age, then you have osteoporosis. Now, the key to know about osteoporosis prediction is that it has great predictability for fracture risk in older individuals over 50, but does not have the same kind of risk prediction for younger individuals. As far as the impact of HIV on fractures, we've seen from many studies over the last 10 years that people with HIV have a greater risk of fractures. And it really starts to become apparent in the older ages above age 50. And this is one of the first studies that looked at the prevalence of ICD-9-coded fragility fractures in HIV-positive individuals compared to the general population. And it shows this very nicely for both women and men, that the split between the HIV-positive and the general population begins around 50 for women and a little bit earlier for men. Subsequent to this, there have been many other studies from the MACs, the Ys, looking at incident fractures, and this sort of plays out as well. Now, I began my interest in this field focusing on postmenopausal women. And this is one of the earliest studies that we performed, looking at a cohort of HIV-positive and HIV-negative postmenopausal women from Columbia University that were matched for race ethnicity. And we found that the HIV-positive individuals had lower bone density at the lumbar spine and the total hip, the femoral neck, than the uninfected controls. We also found that over a 1-year period that the rate of bone loss was greater at the total hip and at the wrist. Later, when we looked at premenopausal women, we found this not to be true. That is, the rate of bone loss longitudinally in premenopausal women was not different between the HIV-positive and negative individuals. So we and others found that the risk of fracture was clearly higher and bone density clearly lower in older individuals. And we wondered, with a lifetime of HIV infection, starting from perinatal infection, whether or not this would greatly impact the risk of fracture in those people who are infected early in life. Bone mass and bone strength is a lifetime cumulative process. And so in our first investigation, we wanted to see whether perinatal infection caused lower bone density at an age in your pre-pubescent age. And here, for this study, we collaborated with investigators in Johannesburg to assemble a cohort of children with perinatal HIV infection who were between the ages of 5 to 9. These children had been part of a randomized clinical trial and started on therapy early, before the age of 3, and were continuously on antiretroviral therapy. We found for the controls, we recruited uninfected controls from their siblings. So had very similar environmental exposure other than the HIV infection. We found that the HIV-positive children had lower bone density and they had lower bone mineral content in the whole body and the lumbar spine, and that this held up after controlling for height, which adjusts for the differences in growth between the two groups. Next, we wanted to see whether or not early in life infection, either perinatally or during adolescence, prevented the attainment of a genetically determined peak bone mass. The greatest amount of bone mass that all of us have is attained sometime between your 20s and 30s. And after that, there's a steady decline, which accelerates in older age, after age 50. And so for this next investigation, we wanted to know whether or not children who were infected perinatally or during adolescence had lower peak bone mass at an age of 20 to 30. For this study, we assembled a cohort containing 3 groups: perinatally infected children at the age between 20 and 25, people who were infected with HIV during adolescence, now between age 20 and 25, and controls who were uninfected. We matched by age and ethnicity. They differed a little between the 2 groups that were HIV positive by the antiretroviral exposure, with more of the perinatals being exposed to protease inhibitor therapy. We found that in comparison to the controls, both groups of HIV positive individuals had lower bone density by DEXA, and in this case, we're presenting the Z-scores. And by using the high resolution CT method, we found that they had between 8 to 18% lower parameters in terms of total volumetric bone density, trabecular bone density, trabecular thickness, and cortical thickness than the HIV uninfected controls. Stiffness is the measure here that we're using to estimate bone strength. And on the HIV positive individuals had lower composite bone strength by stiffness as well. I'm not showing this on this slide, but between the perinatal group and the adolescent infected group, we also had some differences, although not as large as the difference between the HIV positive and negative. Now, what is the etiology of bone loss with HIV? There are host factors, in particular environmental factors like smoking and alcohol use, or hormonal differences like hypogonadism, which is common with HIV, as well as co-infections like HCV infection, which has an effect on bone. There's also the effect directly or indirectly of the virus. There are in vitro studies that have shown that viral proteins have direct effects on bone cells in culture. And there's a lot of data, both from animal models and in vitro models and clinical studies that have shown the association of immune activation, both using cellular markers and cytokines on bone. And lastly, there's the literature that looks at the direct effect of antiretrovirals on either bone cells in culture or using clinical studies. To me, this is the clearest indication from a clinical study of the independent effects of both HIV infection and antiretroviral initiation on bone. And this is the substudy of the START study. And here we see in the dark blue that in the individuals who had delayed therapy for antiretroviral initiation, there was some amount of bone loss, especially at the hip of about 1% during the time of follow-up. Whereas with initiation of antiretroviral therapy, you see a much greater decline, about 2 to 4% during that same time period. This is a slide that compares the quantity of change, in this case just in lumbar spine BMD, with initiation of various antiretroviral regimens. And just looking across the board, you see that there's about between a 2 to 4% decrease in bone density with initiation of antiretrovirals, more so with combinations that contain TDF and FTC. In the last row, I'm showing the impact of changing from TDF to TAF in terms of initiation. And so instead of a 2.9% loss with TDF containing regimens, with TAF using in the same regimen, you're getting only a negative 1.3% change in bone density. And most remarkably, you can see from the newest combination regimens, and in this case, it's bictegravir, FTC, and TAF, there's very negligible change in bone density with initiation. And in this study, comparing that to abacavir, 3TC, and dolutegravir, very negligible change. So certainly this leads us to understand that with integrase inhibitors, you have a very, very low impact on bone. And with newer nukes, such as TAF, and with abacavir, there's very little impact on bone. We can see similar results from switch studies, that switching from TDF to TAF or to an integrase inhibitor like raltegravir, you can increase the bone density by about 1 to 3%. And similarly, if you change from a ritonavir-boosted protease inhibitor regimen to raltegravir, you get an increase in bone density. So what is it about tenofovir that causes bone loss? The amazing thing is that we still don't know for certain. There are 3 different potential mechanisms. One is that there is inadequate mineralization that occurs when people are taking tenofovir. There are data from animal studies that show that tenofovir causes osteomalacia, and that's related to the proximal renal tubular dysfunction of tenofovir. In humans, hyperphosphatemia occurs quite commonly, probably as a consequence of some proximal renal tubular dysfunction, but frank hypophosphatemia, meaning low levels of phosphate in the blood, and clinical osteomalacia, meaning clear evidence that there isn't enough mineral deposition because of the phosphate in the bone, is a very, very rare event. Another thought is that there is a secondary hypothyroidism process that goes on with initiation of tenofovir-based regimens. And that may be linked to a functional vitamin D deficiency with increased vitamin D binding protein, as has been shown by Havens et al., but not in other studies. And lastly, there are data from in vitro studies that show that tenofovir has direct effect on bone cells, that it can increase osteoclast differentiation, which promotes bone resorption, and it also can inhibit osteoblast differentiation, which may produce problems with bone formation or mineral deposition. In contrast, from the studies that have been produced from Gilead, there does not seem to be any effect of tenofovir on their in vitro studies. So some differences in data from that arena as well. I'm going to show some data that we have, which we think are quite novel. A lot of the data that I've shown and others have produced over the years about HIV and antiretrovirals on bone suffers from lack of bone biopsy data. In this very unique collaboration with investigators from Brazil, we were able to do a study which included 20 ART naive men with HIV who had no other known metabolic bone disease, and they had paired iliac crest bone biopsies before and 12 months after initiation of tenofovir, FTC, and efavirenz. From these bone biopsies, we can get a lot of information that you couldn't get just with non-invasive measures like the micro CTs that I was showing you. Here, in the first column, we are showing the bone biopsies from patients before starting antiretroviral therapy, and in comparison to the reference population, which are HIV uninfected individuals, we see that there's a real difference in the dynamic parameters, the bottom 2 rows, in lower bone formation and higher mineralization lag time. So this really shows that there's a problem just with HIV alone on the osteoblast's function of being able to form bone and mineralize bone. We also see that there is higher osteoclast surface and activation, meaning that there's more resorption, as we had suspected from our data looking at bone turnover markers, that with HIV itself, there's an impetus of driving greater bone resorption. After a year of tenofovir, 3TC, and FTC, we see that the parameters that indicate greater osteoblast activity have increased on the top. However, the dynamic parameters below, which show that the bone formation rate and the mineralization lifetime have not changed, demonstrate that there's still a problem with the full function of the osteoblast, that they're able to lay down the collagen, which accounts for the increase in the osteoid, but there is still a problem with mineralizing bone. So now to answer the question, should we still care about bone now that we have less bone toxic regimens? I hope I've demonstrated to you that HIV itself has a negative effect on bone, and what that cumulative effect is on the process is still not very clear. ART switch or beginning ART regimens that are not as toxic may not fully reverse the cumulative effects both of HIV and ART on bone density, or other insults like lifestyle or comorbidities that occur with greater prevalence among HIV patients. And lastly, there are vulnerable populations that I've shown, children and adolescents in their inability to reach peak bone mass, and in older individuals who are at higher risk. I think these vulnerable populations still require us to think about improving management beyond antiretroviral changes. And one last point, that TDF is still widely used in resource-limited settings and may still be for some time to come. So here are some suggestions for clinical management. As far as screening is concerned, when we're screening with the DEXA, we're trying to see who's at greatest short-term risk of having a fracture and requires additional intervention. And here we recommend doing the DEXAs in older individuals only, above the age of 50. As I discussed before, DEXA does not have such great predictive value for younger individuals as far as short-term fracture risk. The other modality that's been talked a lot about in places that don't have access to DEXA is the FRAX, which is an online calculator that you can use to input clinical parameters for patients to derive an estimated risk of fracture. We've shown, and others have shown, that FRAX is less accurate for people with HIV, but if you use the online calculator and you check off the secondary osteoporosis box as an indicator of the potential risk of HIV as a secondary osteoporosis condition, it actually improves the calculator a little bit. You should also screen for and manage secondary causes of osteoporosis if you do find that you have low bone density by DEXA, such as looking for vitamin D deficiency, hyperparathyroidism, subclinical hyperthyroidism, hypogonadism, and phosphate wasting. There are other conditions such as Cushing's syndrome, idiopathic hypercalciuria, celiac sprue, and multiple myeloma, but those are not routinely checked. As far as suggestions for clinical management, for patients who are high risk of fracture, there are some potential things that we can do with antiretroviral therapy. First, for ART initiation, I think you should avoid TDF and protease inhibitor containing regimens, favoring integrase inhibitor regimens and NRTIs such as abacavir or TAF. As far as patients who are on established antiretroviral therapy regimens, for those who have fracture risks and for those who have DEXA evidence of low bone density, I would switch those who are on TDF or protease inhibitor regimens to ones containing integrase inhibitors, and potentially abacavir or TAF if you need an NRTI. As far as what to do for patients who have a DEXA that shows that they're in the osteoporosis range, so less than a negative 2.5 for the T-score, that they don't have a fracture. You could first switch someone who is on an ART regimen, such as ones containing TDF and protease inhibitors, to a new regimen that contains integrase inhibitors or Ivacavir or TAF, and reevaluate the DEXA at 1 year. And this is a way in which you could think about delaying the use of bisphosphonates. Usually after you start the bisphosphonates, you continue for 3 to 5 years, and then you may have to sequence with other bone-specific therapies. We found that in some cases, if you just switch the antiretroviral regimen, you get a 2 to 3% increase in bone density, and you can delay the use of bisphosphonates for some years. However, this is not an option in patients who have a fracture or who have severe osteoporosis, so a T-score less than -3. Certainly, there are still gaps in our knowledge. I still think there's a lot of interesting research that could occur to look for understanding the specific mechanisms of antiretroviral therapy on bone toxicity. As I've shown you from our bone biopsy study, there's a lot of things that we still don't understand. It may involve other studies, such as our bone density study, to be able to elucidate that. Another thing we sorely need in this field is a better way to determine who is at higher risk of fracture or bone loss with ART initiation. And there have been many studies that have looked at bone turnover markers, inflammatory markers, or other biochemical modalities. None of them have been all that helpful. As far as using advanced imaging, such as CT assessment of bone strength, like I have showed you for research purposes, they may be of value, but are difficult to get for clinical patients. As far as what to do about the general population, especially younger individuals, besides antiretroviral therapy changes in terms of nutritional, hormonal, lifestyle modifications, I think those are very important questions that also deserve additional research. And lastly, this is a big problem in the resource-limited setting, given the limitations both in antiretroviral therapy as well as modalities to risk stratify and identify patients who are at risk of fracture or osteoporosis. So I think further research needs to be done in terms of figuring out what are the best and most cost-effective ways to implement some of those measures. With that, I thank you for your attention and acknowledge my collaborators and funders.